Hi there, ladies and gentlemen. Thank you so much for joining us for another educational webinar from Fullscript. Today's guest, I'm going to be joined by Dr. Robert Kachko. He's a naturopathic doctor and is recognized as an expert in the fields of chronic pain, neurodegenerative and brain disease, cardiovascular disease, and metabolic syndromes. His passion is helping people prevent and reverse the chronic diseases of aging they worry about through naturopathic and integrative medicine. To that end, he works to expand access to these approaches through advocacy, national lectures, and media appearances. He's a very busy man, and we're super lucky to have him here today. So without any further ado, I'd just like to kick it off to him. Thank you very much for joining us, Dr. Kachko.
Very good. Well, thank you everyone for joining. I appreciate you taking the time, especially in the middle of the afternoon if you have busy patient or client schedules. Hopefully what we're going to be talking about today is fairly unique and hopefully novel enough that you'll be able to introduce it into your practice tomorrow. And I also want to thank Fullscript for recognizing the need to have this conversation around chronic pain. We're talking about chronic pain a lot in this country. And Fullscript has really been at the forefront of making sure that providers are educated on the types of approaches that would be useful for their patients. So once again, thank you for Fullscript and thank you all for joining. We will be sending a recording of these of this lecture afterward. If you want the slides, you can reach out or reply to the email that was sent to you with your introduction or your invitation to join this lecture with the link that you received. Against my better nature, I made way too many slides. There's so much to talk about here. The way I set it up though, first of all, everything is fully referenced. So if you do want the slide deck, you do have to reach out and ask for it. But I set up the slide deck so that if you want to go back and read through some of this research that we're going to be highlighting, you're fully able to do so. And then what we're going to do is maybe the last 20 slides. I don't really expect to get through all of them. We're going to spend the bulk of our time in the first half to 2/3 of this lecture. The remaining slides, I would say, are all set up from the perspective that if you get the first 2/3 down in your practice in terms of how you talk to your patients and how you talk to them about pain specifically, all those other modalities that are in the last third of the lecture are actually going to be much more effective and efficient. And so to that point, this isn't a talk on how you should practice. This isn't a talk on your modalities. Everyone's got a lot of tools in their toolkit. The goal here is to frame the perspective from a resilience standpoint, to ensure that the way we're talking to our patients and our understanding of what the factors are that contribute to chronic pain are truly biopsychosocial. And so in this pain care model, I suspect most of the providers on this call are practicing some version of integrative medicine, or at least interested in integrative medicine. And what's amazing about pain care is in the last couple of decades, I'd say pain management has been more open to integrative, comprehensive, holistic approaches to care than any other discipline, I would say. And I think in part that's because the tools that we have in conventional pain care, everyone's heard about the opioid epidemic, frankly just haven't been very effective. But also because there's a big understanding, especially coming from the research, so we're always 10 years behind the research, that the only true effective approach to chronic pain is a biopsychosocial one. So biomedical, biological. I'm not telling you how to do your work if you do physical medicine, if you do acupuncture, if you help people with nutrition, all of that is essential. What we're talking about here really today is the psychosocial component of working with our patients. First, why that's important. Next, what some of the mechanisms might be as to what might contribute to pain chronification, and also some approaches and some modalities in terms of what to do about it. Two other important takeaways though. The first is that the language that we use with our patients can either send them in the direction of chronic pain or it can speed up their healing process. It can help a patient who's got an acute incident turn the page and move in the right direction. Just the same language that we use if we point to someone's imaging and say, well, you're going to have this pain forever, drastically increases their chance of having that pain forever because they've put trust in us. But just the same, part of this empowered approach that we're going to be talking about today really values the need for patients to understand that their healing is in their own hands. We've got this model in medicine historically, this sort of paternalistic top-down model, but very often in pain care as well, where patients come in feeling like they're broken, and the only fix for what ails them has to come from their healthcare provider. And frankly, that's a model that never served us, but at this point, it's causing more harm than good. So we're going to be covering a lot of that, but I find that introduction is a little bit important. Very brief intro on me, why it is that I'm talking to you. So Dr. Robert Kachko. I would separate sort of my experience as to how I got here into 3 areas. The first is clinical. I work with InnerSource Health right in Manhattan. Most of my practice historically has been cardiometabolic risk reduction, and then I'd say the other half is chronic pain. I also do a fair amount of advocacy work. I'm incoming president, current president-elect for the American Association of Naturopathic Physicians. I've worked for the last couple of years and was on the board for the New York Association of Naturopathic Physicians, really working to get us licensed in the state. And both of those are means to an end, where every patient understands, every person in this country understands that naturopathic medicine is a choice for them. Integrative, holistic healing is a choice for them. And to ensure that our provider types have a seat at the table, to ensure that as medicine evolves, and it's quickly evolving, the latest research shows every 3 or 4 months, the knowledge we have in medicine doubles. That used to be about every 7 years. And so as it evolves and as policy changes come through, that we have a seat at that table. And then finally, you see on the screen on the very bottom there, a logo for a company that I started with a co-founder about 2 years ago now, called Tribe RX. And basically what we've done is we've recognized the need for these types of conversations that we're going to be having here. We've recognized that it's very hard in a busy practice to have these types of conversations and to offer this kind of psychosocial care. So we created that. We've created a technology-enabled, peer-based program that helps people dealing with chronic pain to connect with others dealing with chronic pain, so having a lived experience of pain, to walk a journey of behavioral change together. And so truly we feel that the future of pain care comes from a lot of different angles, and there's no one right answer, but that psychosocial augment, that psychosocial aspect has to be there. And so that's what we're doing with Tribe. So it's hard to know how many people on this call treat pain exclusively, but the fact is that right now 1 in 3 Americans are dealing with some sort of chronic debilitating pain. According to the CDC, 20 million Americans deal with high impact chronic pain. So that means it's impacting their ability to work or their ability to have a quality of life. This is coming in your door. Patients might not be talking to you about it if you're treating mostly, Hashimoto's or whatever it is that you specialize in, but people are dealing with pain, and our system and our model isn't supporting them. So we have this pain epidemic. We've got an opioid epidemic that's, again, been highly publicized. There's a lot that we need to be doing to flip the script on that. And so this slide is one that I use mostly when I talk to patients, actually. And a lot of these slides, of course, I've sort of increased the level and everything is well cited. But a lot of these slides, the language that's used here is actually patient-centered language. We talk about this idea of how to pain-proof ourselves. And that idea of pain-proof doesn't always resonate with everyone. So the way I think about this model is, what is it about the ecology of our lives? What are the factors in our lives that will help us to be more resilient to pain, that will help us recover quickly from an acute condition without it turning into a lifelong debilitating issue? And interestingly enough, we have a lot of research out there that points to the fact that 2 people can have exactly the same structural damage on imaging and experience very different subjective symptoms. Of course, pain in and of itself is a very subjective experience, but one of the best studies that I know of looked at people with bone-on-bone knee pain, that image that you're seeing on the right of your screen, where you would expect knowing nothing else about the patient, that those patients would be in severe pain. About 40% of people with bone-on-bone knee pain have no pain at all. Meanwhile, people with classically healthy looking joint spacing, if you look at the image on the left, about 15% of the time can still have some form of chronic knee pain throughout their lives. And so I've always been interested in, well, what is it about these people? What are the thoughts that they're having about their pain? Of course, what diet are they eating? How are they moving their bodies? What's their trauma history? And we'll get into that a little bit. What are the factors? What is the ecosystem within which that subjective experience of pain happens? Since that's what we're going to be talking about today. And we've got a couple of curious and interesting findings throughout history. This is an image of the Berlin Wall before it came down, or this might be a part of it that's still up. I can't speak to that very well, but what I can speak to is a curious finding, whereas people who lived on the east side of the wall in East Germany before the wall came down had very little chronic low back pain, whereas people on the west side of the wall, literally feet across, dealt with some pretty severe back pain. And so that was always curious to people, but it was poorly understood. Interestingly enough, just a couple of years after the Berlin Wall came down, the levels of chronic low back pain equalized across the board. And so what was it about the language that was used to talk to these patients? Certainly the structure of their bodies didn't change. It's unlikely that within a couple of years their dietary patterns changed considerably. It's unlikely that there were some new environmental exposures or an increase in things like Lyme disease that can certainly contribute to chronic pain. Within a couple of years, this changed because the way people viewed acute versus chronic pain was very different on both sides of the wall. But we can also look at our modern day, where we have people mostly sitting in offices dealing with severe chronic pain. The latest research shows that as a country, we're spending about $635 billion a year on pain. Well, 74% of that isn't actual healthcare spend. 74% of that is some combination of absenteeism and presenteeism, short-term and long-term disability, and a lot of focus has been spent in the workplace. And so most large companies these days, especially out on the West Coast, have large ergonomics departments to ensure that people's workspaces are set up in a way that's conducive to their body's evolutionary needs. Boeing did a study a couple of years ago now where they looked at a couple of thousands of their employees. And what they discovered was across all factors, ergonomics ended up not actually being a contributor to people's likelihood of missing work because of low back pain. What they found was the biggest contributor, and actually the most statistically significant contributor, was workplace dissatisfaction. Dissatisfaction with your job or with your boss or with the tasks at hand, lack of autonomy in your work. And so the question becomes, is our pain well understood from a structural standpoint, or do we have to look beyond that to, again, the ecology of our lives? And to take that a step further, most chronic pain conditions are actually worse in the developed world, where we theoretically have more resources than people who don't. And if we think about this structural model that we've been using for years, the fact is that in some parts of the world that are not as well developed as the United States and Canada, for example, there's less back pain, even though there's more structural damage to people's backs. They do more back-breaking labor. They're working more with their bodies, and certainly you would expect that that would contribute to more wear and tear based on this wear and tear model, but the research just simply doesn't hold up from an epidemiologic standpoint. And so these findings are only curious if we look at them from a purely structural model. If we take the perspective that there's much more to this picture, those findings become a little bit less curious. And I think one of the most interesting studies looked at people who had no more than 2 days of chronic back pain throughout their lives. It's about 20% of our population that can say that. And they followed them with imaging to see, in the people who had no pain at all, would radiologists be able to predict who was likely to have pain? The radiologists were blinded to the fact that none of these people had pain. They were just shown x-rays and MRIs. And what they found was, and focusing on that age 50 range, what they found was that at age 50, in people who have no pain at all, 80% of people have disc degeneration. 60% have some kind of bulging of a disc, and up to 14%, this is a huge number, have spondylolisthesis, slippage of vertebrae. And so you would expect that most of those people, if we were living in a purely biomechanical world, would be experiencing some form of chronic back pain. The fact is, none of these people had pain at all. And again, all these studies are referenced, so you're welcome to go back and do your reading, hopefully bring it back to your patient populations and your clients that you're working with as well. And so all of this amounts to some language that I alluded to earlier, and it really equals a fear-based model. Patients are told that their bodies are broken, and in fact that their bodies are inherently fragile. I'll borrow an analogy from Ronald Siegel, the great mindfulness speaker, who talks about these jelly donuts separating these heavy bony vertebrae with maybe a strong annulus fibrosis, but that nucleus pulposus can come out. And of course, jelly donuts won't do a very good job of protecting us when we have these strong, heavy vertebrae in between them, and especially if we have physical trauma. And so there's nothing as disempowering as feeling like we're fragile and that we need to be fixed by our healthcare providers. Just the same, patients when they come to their doctor often are giving up their agency and giving up not just their choice in the treatment matter, but also the feeling like they can help themselves, which translates to a feeling like they can't pain-proof themselves, that the choices they make won't actually contribute to their likelihood of dealing with chronic pain. As we know, that's just simply not true. A body that's inflamed, a body that doesn't get the right nutrition, a body that has more oxidative stress is more likely to be one that's in pain. The fact is, patients across the board are not getting that message, and it's important that they do, because that resilience directly contributes to their likelihood of feeling that physical pain. And so the new paradigm, using the language that we'd be using with patients, it doesn't just treat patients as patients, it treats them as people with unique stories that have contributed to their being in your office, feeling that the way they are on a physical level, but there's a psychosocial story that must be considered. The new paradigm looks at a comprehensive biopsychosocial approach. It honors the fact that, yes, of course, trauma or injury or illness in the body can have an impact, but certainly the brain plays an important role here, and that's what we're going to be talking about for much of the rest of this talk. The new paradigm involves the patient in the room. It doesn't just tell them what they have to do, it gets them to actively participate in their care. The new paradigm doesn't just talk about getting rid of 100% elimination of pain. It really focuses on values and what people still can do while acknowledging what's possible from a healing perspective. And finally, the new paradigm doesn't allow people to feel like they're alone in their pain. One of the biggest challenges, specifically with chronic pain, and we're going to speak a lot about this in a moment, one of the biggest challenges is that people often feel like no one else understands them. They don't feel heard. Even though their family wants to help them, they can't fully understand what they're dealing with. And interestingly enough, with chronic pain, the idea of salubrious behavior, health-giving behavior, can actually make people worse, where we get around our family and our back hurts, and every time our back hurts, our partner gives us a massage. Well, maybe our pain exacerbates every single time we're around our partner for that reason. So there's a lot to be said about that, but connecting patients with a lived experience of chronic pain can go a long way in changing their pain perception. I would go so far as to say that, especially with this opioid epidemic, this fifth vital sign that we've experienced, well, maybe people's experience would be different if they came into their doctor and they felt like their pain was a 9 out of 10. Well, maybe it would be a 3 out of 10 if they felt supported and understood, if they didn't feel alone in this journey towards recovery. And that could be pretty scary. And it actually turns on a lot of the mechanisms that activate physical pain. Interestingly enough, though, and we talked about how research often lags by about 10 years, in some disciplines longer, this isn't a new model. Most people are familiar with the gate control theory introduced by Melzack and Wall in 1965. Well, Ronald Melzack came out in 1990, a long time ago now, with a totally new model that he called the Neuromatrix model. We're not going to go into this in full depth, but this Neuromatrix model looks at inputs and outputs. But those inputs go beyond just physical structural issues, and they look at our cognitive evaluative component of what we consider our pain to mean. It goes into visceral input, and there's this idea of interoception and the importance of proprioception. throughout our bodies, but also how our visual and vestibular systems can impact our likelihood of dealing with long-term chronic pain. If those aren't aligned, we're going to talk about that in a moment. And then finally, it talks a lot about the affective components of pain. What is it about anxiety and depression or immune system activation that can actually make our pain worse? And so all of those things contribute in a very real way, in a very complex way, to the person's likelihood of experiencing physical pain in that moment. And so we have to go beyond the gate control theory. For some reason, it's a really sticky idea. It makes a lot of sense. This idea of an inhibitory interneuron sending a signal from top-down inhibition through the periaqueductal gray. It's a great idea. It doesn't hold up, and our bodies and our brains are just far too complex. And if we keep ignoring it, unfortunately, we're ignoring the needs of our patients as well. And so in terms of the psychosocial determinants of pain, people who deal with long-term chronic pain are more likely to feel that something is amiss, that there's an alarm that's going off, that there's some danger going on. And most often those people are also disembodied. They're sort of ignoring their physical body and living up in their brain and in their mind. That's where we'll talk about some ideas around mindfulness and meditation. We have to help people flip the script on those things to reset that alarm, retrain what it is that they're afraid of, and reteach them, for example, if movement is scary for them, that hurt not need equal harm. And so a lot of patients feel like, well, they have chronic neck pain. Every time they rotate their head 20 degrees to the left, their pain gets worse. So they're going to stop moving. Unfortunately, what the research also shows is that in acute conditions, probably the best indicator of recovery and breadth and speed of recovery is a person's is the time between which they felt that injury and they got back to vigorous exercise. And so if people start to lock in and stop moving their bodies, that has other downstream effects. But it's also too simple to say that rotating your head to the left might mean that there's a structural issue there, and so you shouldn't rotate your head to the left. What's possible is that our brains are complex. Our brains are very adaptive, and what they do when we turn our head to the 20 degrees to the left is notice that at 22 degrees, maybe that actually does cause some structural damage. So I'm going to stop that movement at 20 degrees by sending an alarm signal to the brain. And so we need to retrain the safety around rotating our head 20 degrees to the left, and then 22, and then 24 until we get full range of motion. That's why every one of my patients who comes in with chronic pain, we do a full range of motion test on every joint, along with some other neurological assessments. So we'll get into a lot more of that. And to give you an indication of just how much context matters when it comes to chronic pain, there's a group of researchers out of Australia that did a brilliant study. Lorimer Moseley, he's done a lot of publishing in this biopsychosocial pain world. What they did was they exposed people to a certain degree of pain elicited by a probe that touched a very specific spot in people's hands, and the only thing they changed was whether that probe was colored red or blue. And from an evolutionary perspective, our brains have learned to perceive red as a hotter, warmer color as more dangerous than blue, and nothing else was different. The actual temperature of the probe, I think it was 20 degrees Celsius, was the same. The only thing that was different was the environment around which that pain stimulus was presented. And so people consistently had more pain red than blue. That's a small change that had major changes in their visual analog scores and their pain scores and their pain interference scales. Think about how much more complex all the cues that we're sending our brains are throughout the day. And I would venture to say, and this is why we've been working on Tribe for so long, so maybe I'm a little bit biased, but there's no cue that's more important for driving pain chronification than that feeling of being alone and poorly understood. We won't spend too much time on this, but across the board, isolation is a major public health epidemic. It's 2 times more dangerous to be lonely than it is to be obese. It's as dangerous to be lonely for early mortality as it is to smoke 15 cigarettes per day, and that goes across the board for heart disease, cancer, dementia, and chronic pain, as we're going to talk about in a moment. Unfortunately, that challenge is only getting worse. Our patients who come in, if in the 70s, maybe 10 or 11% of them were perceiving themselves as lonely, and that's the important part. It's not whether we think they have a bunch of friends and family who would support them. It's their own perception of being alone and unsupported and poorly understood. To today, and this is a study that was done by the AARP in seniors, about 43% of seniors feel lonely or isolated. In 2019, more people would describe themselves as having no one to turn to in a time of emergency. Maybe the best example is someone to pick them up from an unplanned surgery, then one person. That's not the mean, that's not the median, but it's the most common answers that people feel like there's no one who can help them. And that's a real problem. We're tribal by nature. We have a deep evolutionary need to connect with other people who understand us. And from a neurobiological mechanism, social pain in a very real way drives physical pain. If you go to a party and someone's mean to you or excludes you, it's almost the same from a suffering perspective as if that person punched you in the shoulder and kept doing so repeatedly. Because what happens is the same brain regions light up, and we're going to spend a lot of time talking about the anterior cingulate cortex and the insula and that prefrontal cortex on there. Those same brain regions light up and change their pain inhibitory control on lower centers in the spinal cord, much the same whether it's physical pain and social pain. And so again, the premise is that if your patients are coming in and they don't feel supported, and everyone's had that patient who comes in and at a certain point they're just coming in to talk because they have no one else to talk to, they need additional support because they're really giving you the signals and the signs right there. From the perspective of the research, what's important is that loneliness or isolation actually drives this feeling of hyper-vigilance and a lack of safety. And that makes sense, right? If we were separated from our tribe, it was more dangerous to our lives than being away from food or water for a day or two. We were more likely to get picked off. And so we need to help our patients feel that safety again to reduce their likelihood of feeling hypervigilant around their physical experience. Similarly, people who are lonely tend to create a vicious cycle for themselves because the lonely brain tends to seek out novel objects as opposed to novel people. And so we actually get more dopamine reward from things than from people if we're feeling lonely, and that just perpetuates our cycle, and we're more likely to perceive others as having a negative view of us if we're lonely, which unfortunately continues that cycle. The good news is you don't need to have 10,000, or I guess the cap is 5,000 Facebook friends. What matters is a couple of close relationships, people who you really feel connected to, people who you really feel can support you well. Probably one of the best researchers or the most influential researchers in this world was Dr. John Kachko. And I'm just going to read this whole quote because I think it's brilliant. Unfortunately, Dr. Kachko died a couple of years ago, but I think this quote will continue to reverberate. This idea that natural selection operates across generations, and it is a process that continues. The capacity for feeling loneliness, when viewed from an evolutionary perspective as an adaptive biological capacity, again, an intended consequence, is not so much about a dysfunctional property of humankind that produces personal misery as it is about promoting an individual's genetic legacy. If this reasoning is correct, then loneliness may well be a polygenic trait subject to epigenetic influences, and that's what we find in the research. If we look at the genes, certainly about 50% of the experience of likelihood of being lonely is heritable. And on the screen, you're seeing the 4 most commonly studied genes that look at this interface, and you'll recognize them as SLC6A4, focuses on serotonin transport, and the one on the bottom right is related to oxytocin, the dopamine receptor on the bottom left, and the corticotropin releasing hormone on the top left. Those are all, of course, related to mood and energy production and the way we engage with each other in the world. The amazing part of this research shows that even people, I'm sorry if you're hearing sirens, we're right in the heart of New York City right now, so that'll pass in a moment. But the research shows is that if adolescents or older individuals with these genetic traits, even if these genes are fairly high penetrance genes, the risk and the likelihood of developing depression and anxiety and suicidality plummets when those people got the right social support, either as adolescents from their parents or at the other stage of life as seniors from their children. And so we have an opportunity to reach out and to change from an epigenetic standpoint this polygenic inheritance, and that's a really empowering message. When it comes to working with patients dealing with pain, it's important to understand that what we have to start with is education. A lot of people don't know what they're dealing with until they come see you. They have a vague idea of a disc being herniated or a meniscus being torn. But just starting with the difference between acute and chronic pain can make a world of difference. And so we won't get into all these factors, but truly a complete biopsychosocial approach to chronic pain educates patients. We're going to talk about some of the research on pain neuroscience education in a moment. Educates patients to understand that acute pain and chronic pain are different. That chronic pain is an alarm system that was never turned off by the body, whereas an acute incident of pain is an appropriate response to illness or to damage or to physical trauma. The treatment, as you all know, for acute and chronic pain is very different. A lot of the pain medications that we have are not that useful when helping patients with chronic pain. That's in part why we have opioid-induced hyperalgesia, because our bodies are too complex and too adaptive to be fixed by just one simple little thing. And so certainly we failed to help people with chronic pain. My hope is that this understanding around the opioid epidemic actually sets us on a new course and a new path. And so again, patient education is one of the most important components. And so where that starts is helping people understand, and we're going to talk in a moment about this difference between a bottom-up and a top-down approach, but to help patients understand that even though their pain is in the knee, in that joint that we saw that was bone on bone, their pain isn't actually experienced in the knee, but it's experienced in the brain. And you can get, you can have a homunculus on your desk, and you can have that laminated and run people through all the pain pathways and the spinal thalamic tracts and all that. Or you can just explain to them that yes, there is physical damage potentially going on there, but pain is actually experienced in the brain. And what we have to do is help them understand that that doesn't just mean that you're saying their pain is only in the brain, because that's often what can happen. They go to their doctor and they're made to feel like they're crazy, like they're making it up. And certainly we know the correlation between depression, anxiety, and chronic pain, but pain is never just experienced in the body, and it's never just experienced in the brain. And educating our patients about that is really important. Just the same, we have to help them understand that they have the opportunity for top-down control, that the thought that they have, that their perception and their expectation of what will happen, elucidated by that education that you're providing, can have a direct impact, can have a direct empowering impact on their likelihood to feel long-term chronic pain. And this is really interesting because what the latest research is showing is that most common chronic pain conditions, chronic low back pain is the main reason that people go to the doctor in the US. It's more and more being understood as a chronic stress condition than anything else. Much of our latest research is showing that the challenges with these patients are not so much that they have an issue with their temporomandibular joint or that there's a bladder issue with interstitial cystitis. Instead, it's an amplification of the pain signal in their brain. The process of central sensitization in the spinal cord and in the brain makes people more susceptible, more vulnerable, based on some degree of genetics, but also based on a lot of the psychosocial components we're talking about here, more likely to experience this chronic pain. And there's an old idea in naturopathic medicine, this idea of the theory of the unity of disease, this idea that our bodies are doing the best that they can, and they're manifesting symptoms as a result of some incongruence of genetics and lifestyle choice and mindset. And so the theory of the unity of disease says that most of these patients who are dealing with fibromyalgia are also at increased risk for irritable bowel syndrome and TMJ and endometriosis. So on this list are the 10 common, what are called chronic overlapping pain conditions. You should note them, you should see them when they walk in the door, because the challenge is if you're just treating them for their chronic tension headaches by giving them some magnesium, you're not actually getting to the root cause. And if these patients are manifesting with multiple conditions, certainly you can be pretty clear that some central sensitization has occurred. And there's a concept that's been developed over the last decade, mostly out of the University of Michigan, Dr. Claw, where they basically revised the typical American College of Rheumatology criteria for fibromyalgia. Everyone's familiar with the tension spots, and if you have more than 11, you can diagnose fibromyalgia. Well, they've expanded that criteria to look beyond just physical pain, to look at what else is happening in people's lives around fatigue and energy and cognitive symptoms. And they've created a new risk score that's actually out of 31 points based on a combination of how many points they have that are tender and painful on the classic scale that you've all seen as far as fibromyalgia symptoms. But they add to that the severity of their fatigue, the severity of how they feel early in the morning, and the severity of their cognitive symptoms, along with what are called other somatic symptoms. And this is a little bit of a subjective interpretation by the provider. But if the patient has a lot of other somatic body-based symptoms, I listed here muscle weakness, dry mouth, wheezing, things like that, they're also given a rating from 0 to 3 on multiple domains. What's amazing is that we find, going back to those chronic overlapping pain conditions, there's a degree of fibromyalgianess. It's not my term, it's a term coined by some of the researchers who did this work, that would help us in a fairly direct and linear way to predict the likelihood that someone will have central sensitization and the likelihood that they're going to need more medication and more support based on what they're coming in with. So a person who has 10 of the classic fibromyalgia spots, or even 12, but none of the other somatic type symptoms, is less likely to have this centrally sensitized nervous system than someone who has a score of up to 18. So what the research shows is on a score of 0 to 31, it's pretty linear as far as likelihood of having fibromyalgianess or a tendency towards fibromyalgia, up to a score of about 18, and then it levels off after that. But what's interesting is that they did this study in people who had knee replacements and then also hysterectomies. And in the hysterectomy study, once you accounted for all other factors that might contribute to someone suffering after acute surgery, what they found was every increase on this scale of 1 point led to a requirement on behalf of the patient of a 7 milligram morphine equivalent dose of opioids. And so that's a big deal, right? Just that alone, if we had a better understanding that this patient was susceptible, we would offer different treatment. And frankly, we might not even offer the surgery if there are other factors to consider. So from a comprehensive clinical standpoint, we have to be looking at these types of things. And just a note about sort of failed surgeries, failed back surgery syndrome is a thing, right? It's something that we've all heard about clinically. The truth is about 1/3 of patients who get surgery for back pain feel better. About 1/3 of patients feel about the same, and about 1/3 actually feel worse after the surgery. And so again, stepping outside of this purely biomechanical structural model, we have to understand what are the factors that are contributing to a person less likely to benefit from surgery. If it's not based on just their imaging, okay, they've got a disc out, we have to fix that. Because when the surgeons go back and redo imaging or go back and do another exploratory surgery, most often the structural damage has been fixed, but this person is either feeling the same or worse. And so we have to expand our model a little bit. Probably the biggest driver of this idea of central sensitization is the role of neuroinflammation. We know that a brain that's inflamed has a blood-brain barrier that's more permeable and is more likely to be affected by systemic changes in the body. And so we won't go through all of this, but basically at the top there, you're seeing all the different kinds of insults, whether they be immune in origin like multiple sclerosis, or exposure to viruses or past surgery, or even what we would consider more structural damage like osteoarthritis. All of these things, along with some of the factors that you're seeing on the box on the lower left over here, all of these things contribute to a likelihood of experiencing neuroinflammation. And probably the biggest driver of neuroinflammation are the microglia and the astrocytes in our spinal cord and in our brain. A body that's inflamed, and then subsequently a brain that's inflamed, has higher levels of interleukins, higher levels of all the cytokines, frankly, higher levels of tumor necrosis factor, NF-kappa beta. And what it does is it predisposes that brain to, again, send that alarm system off more readily, to send that signal of danger more frequently to the patient, who then begins to move in the direction opposite of appropriate movement and opposite of the type of social connections that would be contributing. And so it becomes a vicious cycle from that perspective. And certainly neuroinflammation we're seeing is contributing to things like Alzheimer's and Parkinson's and MS and all kinds of cognitive impairment in general, but it's also contributing to chronic pain. And if we're missing that, we're missing a lot of opportunity to help our patients. Interestingly, as an aside, there's some pretty cool research on a class of molecules called specialized pro-resolving mediators. They're downstream metabolites of some of our omegas that we use that we know to be anti-inflammatory, and they're very useful, it seems, mostly in animal models, to quench some of that neuroinflammation that patients are experiencing. So possibly if a patient's lifestyle is appropriate and they're doing everything they need, possibly they would stand to benefit from being recommended some of these molecules. So that's research that should be coming out, more and more every year. So we've been talking at a pretty broad level about the importance of helping our patients understand that they should feel empowered to take charge of their health, and from the perspective that affective experience as a patient's social support, their depression, their anxiety can contribute to pain, and also that there's a strong neurobiological bridge between all those regions. And so some of the core brain regions that contribute not to our discriminatory experience of pain, not where is the pain and what's the severity of the pain, that's mostly experienced in the somatosensory cortices, S1 and S2, but our suffering around pain really lies a little bit deeper and has a big impact from our limbic system, which everyone should be familiar with, and the fear response and that emotional response that we experience. But what we're finding is that the prefrontal cortex and the anterior cingulate cortex have a really important role to play in helping our brain, again, from a top-down perspective, inhibit some of those signals that are coming from the physical body. And so what we know is in chronic pain patients, people have gray matter loss in their prefrontal cortex, and also that the prefrontal cortex is the primary source of connection, the primary source of cortical afferent nerve fibers to the PAG. The PAG is the periaqueductal gray. That's the part of the spinal cord that wraps around the central aqueduct, and probably in that Melzack and Wall model of the gate control theory, but also in the Neuromatrix model, probably our most important contributor to top-down inhibitory pain control. And so even if there's a trauma or an insult at some level of the spinal cord, an active and healthy PAG response, which is influenced a lot by this prefrontal cortex, can play an important role. Now, what we also know is that patients who are likely to catastrophize their pain, of course, the frontal cortex and the medial PFC are really involved in executive functioning and reasoning and planning. Well, if a patient is sitting in your office and they're saying, "Doctor, I'm positive that this pain means I'll never be able to work again, or it means I'll never be able to walk again the same way or play a sport that I love," they're catastrophizing their pain. They're projecting out in a negative affect what they're going to experience 5, 10 years down the line. That directly inhibits the ability of this prefrontal cortex from appropriately activating this PAG. And it also plays an important role, we won't get into all the neurobiology, in pain chronification, in that a lot of the signals through the striatal system are actually different from the prefrontal cortex, and it impacts our ability to produce dopamine and serotonin in some key areas of the brain that are related to pain chronification. You see the tegmental nucleus accumbens there as well. So the anterior cingulate cortex is a little bit different. The anterior cingulate, probably one of the most important regions activated by a lot of these psychosocial experiences we're talking about. What we're finding is this is a part of the brain that's highly plastic, and contrary to what we've known for a long time, actually has the ability to change and evolve and adjust. The important thing to understand here, though, is that our ACC is really involved in two things. You see them listed there under key. It's really involved in our propensity for conflict monitoring and our need to do constant and rapid error detection. So the ACC is really involved in our need to do something, to fix ourselves, to help ourselves. And so a patient who's disempowered and feels like they can't help themselves is directly impacting the ability of this ACC, this important top-down inhibitory pain control area, from functioning effectively. The ACC is also very much involved in error detection around physical movement. And so I mentioned that example earlier about the patient who couldn't turn their neck more than 20 degrees. Well, it's possible that there are some parts of the brain, and we're going to get into them in a second, some parts of the brain that are not functioning as effectively as they could to integrate steady movement, parts of the brain like the cerebellum, and they're sending a signal to this ACC that's saying there's an error. That error isn't being fixed, so I'm going to send a signal to the physical body to stop the movement that's causing that error signal to be sent to me. So it's not, again, an issue in the neck. It's most likely an issue in this part of the brain that's perceiving something being wrong, and that alarm system we're experiencing is physical pain in the neck, which creates, again, a vicious cycle. So a comprehensive assessment around some of the neurobiology of pain. We'll look at the hemisphericity of the frontal lobes, the left and right frontal lobe, to assess if one side of the brain is working faster or slower. The same thing with the cerebellum. And importantly, where we are in space has a big impact on this ACC's perception of whether there's error or not. And so our vestibular system plays an important role. And so our ability to have appropriate proprioception plays an appropriate role in this part of the brain telling us if there's a likelihood of error and thus a likelihood of damage or not. We're not going to get into a comprehensive neurological exam here. I urge you to go back to your neurology text to understand how to assess right to left changes in the frontal lobes, the cerebellum, and the vestibular system. A lot of interest these days on pain genetics and really genetics from a lot of perspective. It's a really sexy thing that people are ordering 23andMe's and they want their doctors to assess it. So if you want, and this is work that you do, feel free to reach out for these slides. These are some of the highest penetrance genes that have an impact on chronic pain. I'm going through this section pretty quickly because we're a little bit short on time. Like I said, we're trying to cover a lot here. But opioid receptor mechanics, COMT mechanics around our ability to break down certain neurotransmitters, again, have a bridge between our affective state, our likelihood for depression, loneliness, anxiety, but also our likelihood for feeling long-term chronic pain and our recovery from surgery, our propensity to experience things like fibromyalgia, and the amount of medication that we might require. I'll just point out on the bottom left, this opioid receptor gene, the mu opioid receptor gene that's probably been most studied around chronic pain. In one study, and the PubMed ID is there for you if you wanted to look it up, a full 4.7% in a male population, a male cohort of people, of the likelihood to experience chronic pain over 5 years. This is a pretty long longitudinal study. Full 4.7% from one factor alone, which was having the G variant of this particular SNP on this one gene. 4.7% was contributory. Among all the other possible factors we're talking about, it's important. I urge you to start looking into this with your patients if you haven't considered that yet. And we've been talking a lot about the role of safety and our brains setting off alarm systems when it comes to chronic pain that are maybe inappropriate or no longer effective for our healing. There's tremendous research across the board on adverse childhood experiences, things like family members who are alcoholics when we're growing up, physical abuse, sexual abuse, but even being a child of divorce contribute to a higher ACEs score that research has shown also contributes to the likelihood of experiencing chronic pain. We're going to get into the why of that in just a moment, but there was a pretty large study that looked at a British cohort that found that people with higher levels of traumatic stress based on recall at age 7 actually had higher levels of chronic pain at 45. And all of the 6 determinants that they predicted would be contributing from a fibromyalgia model were actually contributing irrespective of gender and age. So what they found was all 6 contributing scores on the ACEs scale actually contributed to a higher likelihood of fibromyalgia. We think in part that's because of impaired autonomic dysregulation. Our autonomic nervous system through our sympathetic and parasympathetic components certainly drives a lot of the neurological mechanisms we've been talking about here. Certainly the parasympathetic nervous system is responsible for a feeling of safety, and it seems that people who have been traumatized early on in life are no longer able to switch effectively between their sympathetic and parasympathetic parts of the nervous system. Most of the research that's been done in that realm has been done via assessing heart rate variability and some of the domains, the high frequency and low frequency domains and changes there based on a person with a trauma history. Borrowing from the work of Peter Levine, though, I think we would take that a step further, and it fits pretty neatly into the model we're talking about here, this idea of an alarm system that's gone awry, this idea of central sensitization, and a body that doesn't feel safe to move. Peter Levine is a psychologist who's done who's contributed a tremendous amount to the work of people who treat trauma. He's the guy who started somatic experiencing therapy, and they've been teaching it now for a couple decades. And he breaks down the type of memory we have into explicit and implicit memory. And I would venture to say that the type of procedural memory, we'll talk about that in a sec, that contributes to an inability to break out of a traumatic event, whether that be post-traumatic stress at a time of war or sexual abuse. I would venture to say that that contributes much to chronic pain, chronic physical pain in a similar way. And that's because these are parts of the body and parts of the brain that we're not under conscious awareness of. So if we look at explicit memory, that's the declarative memory, the laundry list that we remember. That's episodic memory, the autobiographical story of who we are, sort of our narrative selves. We're consciously aware of those parts of our memory. When we look at implicit memory, that's more the emotional triggers that we're not aware of. You're walking down the street and there's a smell of someone's cologne and it triggers you in a certain way. That's the emotional part of it. Procedural memory, though, procedural memory is body memory. It's a feeling like you can't move effectively, most often triggered by a severe traumatic event where you weren't able to bring yourself to safety. We'll use the example of someone who's experienced post-traumatic stress in war. If a bomb goes off, our body's natural tendency is to move away from that explosion, but there's not enough time for that. And that actually freezes us into this procedural mindset that makes it very hard to come out of that frozen state. And so when it comes to trauma work and when it comes to physical pain, if we had a physical trauma to our low back and it froze us from a procedural memory perspective to feel like any movement that we do is dangerous, we're much more likely to send off that alarm system, whether it's psychosocial trauma or physical trauma. And this is all because our bodies really are error detection machines. We have what's called a false positive bias, where just in case it's a saber-toothed tiger coming through the bushes as opposed to a child running out after grabbing a ball that went into the bushes, just in case our bodies freeze in an effort to run away or fight. And that constant freeze response in a nervous system that's primed based again on trauma or severe physical traumatic history is now sensitized to experience chronic physical pain. There's so much more to be said about body memory and the work of Peter Levine and somatic experiencing. I urge you to look at his book, Trauma and Memory. And so this brings to mind this idea that some patients who walk in our door actually have what would be called a pain personality. And so when we look at the research, we find that patients who have a pain personality, who tend to chronification of their pain and also to opioid use disorder, have three things in common across the board. They have low self-efficacy. We keep talking about the need for an empowered model. They feel like they can't help themselves. They're more likely to catastrophize their pain, and they're hyper-vigilant around the pain. Everyone knows someone, when you walk into the room, they have a really strong startle response. To me, that's one manifestation of hypervigilance. They don't have an opportunity to smoothly transition from known to unknown. People who have all these three components tend to have a higher likelihood of all those chronic overlapping pain conditions. And our job as providers is to flip the script, right? Is to help them feel self-trust, like they can take care of themselves, to give them a better understanding through a lot of the education we spoke about what it takes to get out of pain. And we have to help them feel a feeling of physical safety. So we've got just a couple minutes remaining. What we're going to do is talk about now about some of the therapeutic considerations when it comes to pain. What is it that helps people move from right to left in terms of experiencing no pain at all, no matter what their structure shows them, which requires two important takeaways. The first is that paradoxically, wishing pain away actually makes it worse. And the second is that if we help our patients focus on a quality of life, as opposed to a complete elimination of pain as the only goal, they're paradoxically more likely to have less pain at the end of the day. It also requires our patients to understand this idea of the alarm system and the fact that we can send this system through some of the neuroplastic changes that you can choose to educate your patients or clients about. This alarm system can change, our brains can change, and we have the power to do so. The language we use, we talked about this idea with the ACC around suffering. I do a lot of clinical hypnosis in my practice, so I have a direct tool. You can use whatever tools you need, just education can do it. The prefrontal cortex we've spoken about, the anterior insula on the bottom right, it's really our body's internal thermostat. It's the part of our body that helps us understand if we're safe, if we're whole, if we're damaged. And it again has a direct connection to some of the parts of our brain that help us experience physical pain and some of that top-down inhibitory control. And so if we're looking at a toolkit, we're not going to get into a lot of this because you all have very different toolkits. There are some foundational recommendations, and then there are some condition-specific recommendations. And so if you ask for these slides at the end, The condition-specific recommendations are around osteoarthritis being the most common pain condition. I thought that was most appropriate. No matter what you're using in your toolkit though, the language that you use, I'm going to keep bringing this home because it's the most important point, has to help our patients return to a feeling of safety around movement, around thought, and around their emotions. So this is my toolkit. I use nutrition, mind, body medicine. I help people repair their gut. I help them move in a way that helps their brain understand that they're now safe to do so. I use other brain-based therapies like acupuncture in my practice. I use electric stimulation, and then all the foundational stuff. You got to help them sleep. You got to understand if there's an environmental trigger for their pain, you have to retrain their immune system. Sometimes look at genomics. And of course, we use botanical medicine a lot in naturopathic medicine. This is how I consider most of my patients and their experience. I make sure that on the y-axis, if we're looking at a top-down approach, a pain inhibitory approach, and on the x-axis, we're looking at a bottom-up approach, physically helping the body. I make sure that the modalities I'm using are actually impacting both. And so whether I'm doing biofeedback with a patient or acupuncture, I know that I'm addressing both their brain and their body in a specific way. Everything we're talking about here, this idea of educating our patients and empowering them to feel better, is proven to work. The latest meta-analysis around a modality called pain neuroscience education, combination of 13 studies showed that not only does it reduce pain directly, it enhances people's movement, it enhances their feeling of safety, it reduces healthcare utilization, which is essential if we're going to get these things funded by insurance companies. And certainly pain neuroscience education from a number needed to treat perspective is by far blows away a 2-to-1 number needed to treat for helping people with pain improve function, blows away some of the gold standards we have. Gabapentin's number needed to treat is 6. Most SSRIs, which are commonly prescribed for pain, is about a 7-to-1 number needed to treat. So that's important. These are 2 resources, Pain Neuroscience Education from Lau and his team, and then Lorimer Mosley has a book called Explain Pain Supercharged. I encourage you to read them. I think they're really good resources. They have a lot of really important analogies and metaphors that you can use in educating your patients. We spoke a lot about the mind-body connection. Certainly whatever tools you have to help people be more mindful in their lives, it's important. Research shows that an acceptance and commitment therapy approach grounded in this understanding that people are moving towards their joy, finding what they value, and then physically being embodied and remembering how that felt for the first time, possibly in a long time, does help actually reduce pain outcomes. Similarly, mindfulness meditation has been shown to be effective. And so if you've got a mindfulness practice that you teach your patients, it's an evidence-based approach. I encourage you to keep doing it. We're not going to talk about the rest of this, but again, ask for the slides in our remaining minute. The importance of sleep and some of the factors related to sleep, this will all be on there. The importance of self-management, again, teaching people to self-manage their pain really improves their outcomes. Teaching people to express themselves effectively. This was a specific treatment around emotional awareness and expression therapy, but just having people journal can go a long way. Teaching people that it's safe to move, and then in your practices, based on your understanding and based on your specific assessment for the patient, helping them properly pace their activity so they don't overdo it is essential so that they can, again, understand that movement does not equal danger or harm. The posture and ergonomics we spoke about. There's electrical stimulation techniques that are well proven to work. Acupuncture is something I use in my practice, certainly effective, certainly proven to work, and the effects are shown to last and actually make lasting brain changes. So we all love acupuncture. Diet works. I don't have to tell you that, but there was a 2019 recent review of 23 studies that looked at the importance of nutrition, chronic pain, unequivocally said the food that people eat, impacts their likelihood of dealing with chronic pain and being inflamed. Some of the key nutrients I'm sure you guys are all prescribing in your practice. Helping people lose weight, every pound of weight lost is 4 pounds of less load on the knee joint. So with knee osteoarthritis, if we're talking about an osteoarthritis model here, of course, helping people sustainably lose weight that honors their body at the same time is an important approach. And then as far as some supplements and some nutrients that are effective, with all of these, we look at, well, how does it compare to the gold standard? And the gold standard is often NSAIDs. And so we have interesting research that shows less side effects and similar efficacy for things like curcumin, our omega-3s, bromelain, again, ask for these slides. The part of soybean and avocado that can be turned into soap, which is a funny little ingredient, has actually been shown to reduce pain, but also seemingly to help us maintain joint spacing. Topical capsaicin has been shown to be effective for arthritis. Boswellia, an endangered species, maybe not great to use, but it certainly works for knee OA. And then everyone likes to use chondroitin and glucosamine. It looks like chondroitin is more effective for reducing pain based on the research, glucosamine more effective in reducing stiffness. Both of them are important to address, and that's why they're often proposed together. Thank you for bearing with me. I know we just covered a lot. Ask for the slides. They'll be sent to you. You can go through it at your own pace. Every single thing we spoke about has a PubMed ID or a reference on there. And so I encourage you to change your approach in speaking to patients if you aren't considering these things, because we truly have a responsibility to set people on a course and on a path. And if we're telling them that what they've always thought, which is that they're broken and they need us to fix them, and that's the only way they'll get better, if we continue to take that approach, unfortunately, we're just contributing to the problem. Thank you again to Fullscript for allowing me this podium, and I will get off my soapbox in a second and ask Cameron if we have any questions that have come in. Cameron, are you still there?
Yeah, I'm not seeing any questions currently there. There might be one or two coming in. I can see some people.
I see a lot of requests for the slides.
Right now, there's nothing. For the slides, yes, I'm getting requests for the slides.
Yeah, so definitely send an email. Love the slides. And if you shared your email here, I would encourage you. Cameron, can you just say what email they should be emailing for that, just to make sure?
Yeah, you can email webinars@fullscript.com, and I'll be getting to all those requests.
Very good. Yeah, lots of requests for the slides. We did cover a lot. I appreciate you all bearing with me, even a couple of minutes after time. If anyone has questions for me, you can email me at drkachko, Dr. Kachko at innersourcehealth.com. My marketing people would be upset if I didn't say follow me and our practice on Instagram at dr.kachko. Make sure to follow Fullscript as well. They're doing a lot of really great work, and the same thing on Facebook. Thank you, thank you, thank you. Hopefully this had an impact on how you treat your patients tomorrow.